Thank you so much for that introduction, and thank you everyone for being here. It's really my pleasure to speak with you this morning as we kind of near the home stretch toward the holidays. I do not have any financial conflicts of interest to disclose. So I think most of you in this audience are probably familiar with the fact that burnout among clinicians is increasingly being publicly recognized as a serious health problem, as we see on this slide. And it's also a threat to the nation's public health because of its trickle-down consequences for patients. The problem, of course, began long before COVID, but it's only intensified in the pandemic's wake. Clinician burnout has led to widespread staffing shortages, frequent job turnover, and really an occupational crisis across the spectrum of healthcare providers. So what is burnout? We hear this word a lot in our popular culture, but I want to make sure that we define it clearly. According to the World Health Organization, burnout is an occupational syndrome resulting from chronic workplace stress, and it's characterized by three primary dimensions. The first is energy depletion or exhaustion, which is often described as emotional exhaustion. The second is mental distance from one's job, which is often described as depersonalization. And the third is a reduced sense of professional efficacy or competence. There's a robust body of research showing that clinicians, and physicians in particular, are at high risk for occupational stress and burnout. But most of the interventions have targeted individual clinician resilience. And we know that for the most part, this approach is not very effective. So over the past few years, researchers have increasingly been calling for systems-based approaches that go beyond asking individual clinicians to heal themselves through interventions like yoga or mindfulness training. And this has led some researchers to call for really a thorough reframing of how we understand the problem of clinician burnout. The standard approaches in medicine to combating burnout have emphasized self-care strategies such as sleep, exercise, and eating a healthy diet. And there's nothing wrong with that per se, right? These are all things that are good for all of us. But on their own, they overlook some of the more important causes of burnout that are not subject to individual control. So I find this metaphor of upstream and downstream thinking helpful for really trying to get at the root causes of burnout. And this metaphor was introduced by the medical sociologist and epidemiologist John McKinley in 1975. So it works like this. Suppose that you're standing behind a river and you hear the cries of a drowning person. What are you going to do? We're all clinicians in this audience. You dive in to save them, only to hear another cry for help nearby. And again, you're diving in to save this drowning person without stopping to consider the source of the problem. Why are all these people drowning? And in this case, the problem is caused by the fact that further upstream, someone is pushing them into the water. And I think that this metaphor really highlights the need to move upstream to understand why so many healthcare workers are drowning. It's not that the downstream approaches are completely ineffective or that they're inadvisable, but on their own, they can't really address the root causes of the problem. So this graphic addresses some of these additional upstream sources of burnout. They include sociocultural factors like the politicization of science and public health, as well as structural racism, healthcare systems factors like administrative burden and technology, organizational factors like workload and work hours, and workplace and learning environment factors like harassment, violence, and discrimination. These discussions of clinician burnout have become so fraught that some scholars have even criticized the very language of burnout to describe this problem. So Simon Talbot and Wendy Dean's 2018 essay in Stat First Opinion went viral for arguing that the systemic issues at stake here are much deeper than physician burnout and should actually be called moral injury. And they said, the concept of burnout resonates poorly with physicians. It suggests a failure of resourcefulness and resilience, traits that most physicians have finally owned during decades of intense training and demanding work. We believe that burnout is itself a symptom of something larger, our broken healthcare system. And more recently, this past February, Eric Reinhardt, who is a physician and anthropologist, argued in the New York Times that physicians aren't burned out, they're demoralized by the broken system. He said, the burnout rhetoric misses the larger issue in this case. What's burning out healthcare workers is less the grueling conditions we practice under and more our dwindling faith in the systems for which we work. What has been identified as occupational burnout is a symptom of a deeper collapse. We are witnessing the slow death of American medical ideology. And I think both of these conceptual interventions, this idea of moral injury and this idea of demoralization, are designed to try to shift the focus of blame from the individual distressed clinicians to this idea of a system that is in distress. In 2019, the National Academies of Medicine proposed this conceptual model of burnout and clinician well-being that tried to incorporate some of these systemic sources of burnout. So it's a socio-ecological model that's characterized by these concentric circles that we see on the model that get that increasingly incorporate broader and broader environments. And here, this model emphasizes how external social, political, and economic factors layer onto organizational factors and then intersect with individual mediating factors that lead to clinician burnout. It also shows how these clinician outcomes have consequences for patients, healthcare organizations, and society at large. And I have been using this model in conducting research on clinician burnout and well-being since early 2021. And I wanted to show you data from two really quite different studies that can demonstrate the value of using this sort of a model to frame contemporary burnout. So the first study is the Study to Examine Physicians' Pandemic Stress, or STEPS, which was funded by the Greenwald Foundation and the National Institute of Occupational Safety and Health. I'm the PI, and the study was carried out with collaborators at UNC, my institution, along with the Hastings Center, UCLA, and University of Miami. The project included 2 comparative studies of frontline physicians caring for hospitalized COVID patients in 4 US cities. And we included physicians practicing in hospital medicine, emergency medicine, critical care pulmonology, and palliative care. And we conducted qualitative interviews over Zoom, asking questions about their professional training, the onset of the COVID-19 crisis, institutional practices and policies, working during the pandemic, and their own personal well-being. For the Greenwald study, which began first, we decided to focus on New York initially because it had been the epicenter of the US outbreak beginning in March 2020. And New Orleans provided an apt comparison because it experienced initial surge conditions at roughly the same time, yet offered sort of a different racial and social demographic that provided an apt comparison or an interesting comparison. And then for the NIOSH study, which began 8 months later, we chose LA and Miami because they both peaked relatively later on. And they also have different political climates, which made them ripe for comparison. The final sample across both projects included 145 physicians. Most were under the age of 50, just over half were women, 70% were white, and 90% were non-Hispanic. And they worked in a total of 44 distinct hospitals with diverse funding structures, sizes, and patient populations across the 4 cities, with about a third of them working in safety net hospitals. To show you how external environmental stressors shape physician burnout, I want to share a case with you. Dr. Gupta, a pseudonym, was a hospitalist who had graduated from her internal medicine residency during the pandemic and was working as an attending physician in a public hospital in Miami that served a predominantly Latino underserved population. Dr. Gupta was disillusioned by the way that the pandemic unfolded in Miami. The dissonance between the indifferent response of the state government and local community to public health measures on the one hand, and the dire conditions within her hospital on the other, was deeply unsettling. While in her view, the city of Miami had responded appropriately in mobilizing necessary supplies, she experienced the fallout of significant misinformation at the state and national levels. She recalled, "We would have the governor come and talk to us in our hospital system and say that the pandemic was under control and that people weren't dying and the numbers were right. And meanwhile, we are struggling. So I think there was a lot of misunderstanding that went around that contributed to a lot of negative feelings that healthcare providers had. During the surge of August 2021, Dr. Gupta's hospital experienced high turnover of nursing staff, as many left to take locums jobs offering higher compensation. The administration brought in reinforcements, but much of the new nursing staff was unfamiliar with the hospital systems, producing strain on the system and the long-term workforce. At the same time, Dr. Gupta and her colleagues grew frustrated with this seemingly preventable surge, which occurred after vaccines were widely available. This led to anger, and anger in turn to shame. A year after vaccines were widely available, Dr. Gupta said, "There's not an excuse anymore. I don't get it. And then I feel really guilty that I fail to understand people's perspectives." Dr. Gupta explained that a good physician should have empathy for her patients. There was no place for such anger and resentment in medicine. So just to kind of draw out some of the themes that came up in Dr. Gupta's case, the main stressors reported in the external environment included caring for COVID deniers and dealing with rising anti-physician sentiment, government messaging that minimized the severity of COVID-19, the federal public health response, which worsened the pandemic, fluctuating CDC guidance, which created distrust, uncertainty, and frustrations. Employment and labor patterns in the external environment also contributed to sources of stress. So the national nursing shortage led to increased workloads and suboptimal work conditions for physicians as well as nurses. On the other hand, living in a state or city that took the pandemic seriously was noted by some participants to have a protective effect. An emergency medicine physician working at a public hospital in Los Angeles told us, "It was the sort of ivory tower disregard for the pandemic that was contrasting with our day-to-day lived experience that was very hard to reconcile and very hard to not hate and feel very angry about. I think I feel very fortunate to live in Los Angeles, where I feel that in a local level, we've erred on the side of being overly strict. I would say from a federal level that was really jarring, and I think really contributed to a lot of mental health issues and troubles that a lot of us were experiencing, was the rhetoric from the government that this didn't exist and this was a hoax and this was whatever when we were living in fear of our lives." So I think this excerpt speaks to both the effects of federal policy on individual clinician mental health, as well as the protective effects of living in a city that took the pandemic seriously. This next quotation highlights the role of social media in perpetuating stress. This physician said, "I think social media really created a lot of stress for all of us because say you just had the worst day of your life, and then you come home and you're reading someone's Facebook post about how COVID isn't real and doctors are getting paid for COVID." And then another emergency medicine physician explained how nursing staffing shortages impacted physicians. She said, "You just work harder. You do jobs that aren't yours. I feel like I go into a little bit of disaster mode in terms of how I treat presentations that come in." So now I want to share another case, one that highlights organizational stressors contributing to burnout. Dr. Chan, again a pseudonym, worked in a county hospital in Los Angeles that served a predominantly Latino uninsured population. He described his hospital's response to the pandemic as reactive rather than proactively anticipating challenges. He further lamented that his hospital administration had no idea what I do on a day-to-day basis, and that they issued directives without first inviting dialogues about problems and possible solutions. He explained, "That to me really eroded my sense of value and my sense of loyalty or duty to the hospital. I hated it, to be quite honest." Dr. Chan confessed to feeling pretty burnt out. He attributed this in part to changes in the workplace culture that had diminished the pleasure he took in his work. Before the pandemic, he relished the camaraderie of his hospitalist group. While on the wards, he would catch up with colleagues, many of them younger physicians, whom he enjoyed mentoring, and chat in common workspaces. But during the pandemic, he said, "We don't really do that anymore. It's become much more of a get in, do your work, get out." So this was partly because of the need to limit unnecessary contact during the pandemic. The county had also started cracking down on the amount of overtime that they billed for. Consequently, physicians were now encouraged to leave when their work was done. In addition, Dr. Chan's division office had been moved twice during the pandemic to progressively smaller rooms. No windows, no sink, no bathroom, and it literally feels like you're in a jail cell. And so nobody wants to stay there and hang out. So I think the culture has changed and that we haven't been able to really grow as a division or feel like we're part of a division anymore. Dr. Chan missed feeling that work was fun. He hadn't been happy there in a long time. So the second layer of the National Academies of Medicine model that I showed you refers to the healthcare organization. And institutions really varied in their uptake of precautionary measures with consequences for physicians, particularly early on. Visitor restrictions were one of the most common stressors reported at the level of organizational policies and practices. And wellness programming, which increased during the pandemic, was for the most part not seen as helpful at addressing the underlying sources of stress. In terms of organizational culture, participants lamented that administrative leaders did not understand their working conditions, often because they didn't take the time to show up and visit the wards. On the other hand, participants felt valued when administrators showed gratitude for their work. And many reported that being in the trenches together strengthened bonds among clinical teams. A hospitalist at a public hospital shared, if they would just lower the workloads and had more people, that would solve 90% of it. But I don't think anybody is willing to do that because, that will affect their bottom line. But they can just roll out some workshop every 6 months and then they say they're doing something. Here, a hospitalist speaks about how his hospital administration's neglect of his concerns and experiences diminished his institutional loyalty over time. One of the biggest frustrations I had was feeling like I wasn't even heard. My opinions didn't matter. For me, that was incredibly frustrating. Hospital administration has an idea of what they want to happen, and I certainly can appreciate their global view of things, but they have no idea what I do on a day-to-day basis. And that to me really eroded my sense of value and my sense of loyalty or duty to the hospital. In contrast, this hospitalist praised his institution's communication practices, noting how frequent communication was comforting and helped to generate goodwill. He said, our institution was very good at communicating. So we would get at first daily emails, and then it spread out to weekly and then biweekly. But I actually felt really comforted by receiving those messages. Finally, individual factors like age and years of experience also affected how individual physicians experience the crisis, as this excerpt illustrates. I don't think I realized at the time, but I was having panic attacks. That became an issue for me. It was from, I guess, PTSD or whatever was happening. Just the volume of work being too much or more than I was used to and feeling undersupported or unsupported. And part of that was I was so quick out of residency. I was so green to being on my own anyway, and then sort of being thrust into this situation where we didn't have any data and didn't even know how to take care of these people. And I already was still learning how to do this on my own. That was a challenging part for me too. And I think what's worth noting about this particular excerpt is that this is from a pretty inexperienced hospitalist who was a nocturnist. And in addition to supervising the hospital medical wards overnight, she was also responsible for overseeing the ICU with very little experience. And I think that contributed to this really extraordinary distress that she felt. Whereas if she was working in a different kind of practice setting, she might not have that responsibility. Okay, so I think the STEPS data illustrate how clinician well-being is shaped by multiple social, policy, and organizational factors that structure contemporary hospital workplaces. Adopting an occupational health lens on clinician burnout means shifting our focus from distressed workers to hazardous work environments. So how should we do this? First, by flipping the conceptual framing of burnout to begin with hazardous work environments rather than individual mental health and individual coping strategies. Centering problems in the work environment is crucial for tackling this complex, multidimensional problem. Solutions for burnout must therefore lie with changing environments as well as with supporting workers. Second, by prioritizing analysis of and response to the structural conditions that lead to distressed work environments. Doing so requires going beyond standard epidemiological methods and tools, and this enterprise can be enhanced by collaboration with social scientists and historians who can offer different forms of evidence and insights into the structural drivers of workplace distress, such as staff turnover and labor shortages. I think Dr. Gupta's case highlights a possible role for institutional advocacy as well, such as in investing in community-based vaccination campaigns. And third, by adopting measurement approaches that incorporate organizational level metrics for understanding clinician burnout and well-being. So one of the approaches that I'm engaged in a new study that we're just getting off the ground is the measurement of organizational resilience, which is an organization or unit's ability to adapt and perform in the face of stressors. And this is a really interesting approach that has been used a lot in engineering, but has not been systematically adopted in medicine. So I think these kinds of metrics or tools can help to provide a different sort of lens on how we think about clinician burnout. So I now want to switch gears and tell you a little bit about a different study. And this is the study of OBGYNs in post-row America. SOPRA is just directed by Erica Sabbath in the Boston College School of Social Work. I'm a co-investigator, and I'm joined by my UNC colleague, Kavita Arora, and our project coordinator, Sam McKechnie, as well as an advisory board. So I'm going to begin again with a case, and this is about an OBGYN whom I'll call Dr. Roebuck. When we interviewed Dr. Roebuck last spring, she and her spouse had recently moved out of their state. Dr. Roebuck began her interview by referring to an incident that had taken place the previous year in an outpatient clinic in her state in which a patient shot and killed a physician. With the Dobbs decision looming, the shooting prompted Dr. Roebuck's family to begin making plans to move. The first several months after Dobbs were the nail in the coffin for Dr. Roebuck. Her hospital's lawyers interpreted her state's aiding and abetting clause in such a way that she could not provide any abortion referrals or even discuss abortion at all. She spoke of being afraid that she would be recorded and that the recording could go public and she could lose her medical license. When she started to do media interviews about the impact of the Dobbs decision, her hospital ordered her to stop. She told us, "I really hated not being able to talk to my patients and having legislation that said I cannot talk to my patients about certain things. So that, in combination with the gun control issue, are really the only reasons we left. They were so desperate to leave that they moved without jobs." Dr. Roebuck is one of 54 OBGYNs whom we interviewed for SOPRA between March and August 2023. And the overall objectives of the study were to understand and characterize US OBGYNs' perceptions of the personal and professional impact of practicing under post-Dobbs abortion bans, and to identify and disseminate practices that would support OBGYNs' professional well-being in a restrictive policy environment. And the second piece is what we're currently working on now, moving into the second year of the grant. Physicians were eligible for the study if they practiced obstetrics and gynecology in any of the 14 states that had abortion bans on record at the time of our data collection. And they were purposefully sampled to create a balance in geographic representation, demographics, and hospital types, and they were compensated with a $75 gift card. Data included semi-structured interviews conducted over Zoom with questions about practice background, perspective on abortion bans, clinical practice and moral distress, personal and professional well-being, and institutional practices and policies. Our final sample included 54 OBGYNs from 13 of the 14 eligible states. And so you can see here, we got representation from all of the states that were eligible at the time except Mississippi. And we interviewed between 1 and 8 physicians in each of these states. The mean age of our sample was 42, 81% identified as female, and 83% identified as non-Hispanic white. Most were general OBGYNs, about half worked in academic hospitals, and about 3/4 worked in urban environments. One of the major findings of our study was that moral distress was highly prevalent. Moral distress is distress arising from a situation in which a healthcare provider knows the right course of clinical action, but is barred from taking that action by external or policy constraints. And 50 out of 54 participants in our study reported such situations arising from their state's abortion bans. They repeatedly use words like muzzled, handcuffed, straitjacketed, and like my hands were tied in describing these situations. So one OBGYN told us, I think more than anything in these situations, just the inability to act is what frustrates us the most. And of course, waiting till the patient gets sicker. Once the patient becomes infected and they're still pregnant, any sort of delivery process is more dangerous. If they're infected needing antibiotics, then that puts them at risk for hemorrhaging and longer hospitalizations afterwards, sometimes needing ICU admission depending on the scenario. And when the interviewer asked, how does this make you feel? They responded, horrible, frustrating, and very infuriating. I trained a long time to do what I do and continue to train. I've always felt educating patients on their choices and their options and then allowing them to make decisions is the ultimate goal. So here, the participant refers to this situation as a moral injury. Again, hearkening back to that language from Simon Talbot and Wendy Dean that I introduced earlier. It's just frustrating when you're trying to do your absolute best for a patient and bending over backward to get them into the emergency room on a Friday night to get a surgery lined up, and then run into systemic barriers that don't allow you to do the best medicine that you could do. It's a moral injury, right, to the way that you practice medicine as an ethical clinician. Most participants described fellow OBGYNs as sources of support, but some discussed how the laws had driven a wedge between them and their colleagues due to different levels of risk tolerance in the current legal environment. Several spoke about nursing, anesthesiology, and operating room staff feeling skittish about participating in abortions for fear that their own licenses were on the line, as we see in the following quote. I know 2 of my colleagues didn't back me up, and then I also know that anesthesia was very reticent to do much of anything. So they were not willing to help either. So now we go from issues in the obstetric realm to issues in the anesthesia realm. Is nursing willing to support you? All those issues. Other participants wondered whether these colleagues would report them for violating laws, even in cases legally cleared to proceed. Consequently, they reported feeling more on guard at work, as this quote illustrates. I do feel a lot of the time I have to be very careful how I talk. And this with nurses in the hospital, my colleagues, whatever, you got to know who's on your team and who are your safe people. It's almost like we even feel our safe space shrunk a little bit because now we got to be more careful about how we talk. The majority of participants reported symptoms of strained mental health, including anxiety and depression, because of fears of legal consequences and related stress. One person told us, I cannot overstate how personally stressful it has been, how much it has increased my personal stress and anxiety. Participants reported wondering, is this the case that's going to make me a felon? Several indicated that they did not feel fully present at home due to constant worrying. The most common effect on physician health included sleep disruption and weight gain. Now, it's worth noting 16 participants felt that their state's abortion ban had not increased their stress levels. And this was often because of abortion restrictive institutional policies that predated Dobbs. So they said, our practice hasn't changed that much because of Dobbs, because we already were not providing abortion in this hospital. And these participants who didn't report major health impacts were more likely to be male. So 6 of the 16 were male. Many participants mentioned mistrust of physicians sown during the COVID-19 pandemic and noted that Dobbs came at a time when morale was at a historic low. The additional stress imposed by state abortion bans led to a loss of pleasure for many OBGYNs. Navigating legal constraints was exhausting, and being unable to provide care that they had been trained to perform was demoralizing. Consequently, many participants reported that the stress imposed by state abortion bans had led to a loss of pleasure in their work. One said, I don't find the joy in it. I can't say I regret doing it because I know that it's mattered, but man, it's not fun anymore. And another said, I love my job and I'm so happy and I feel fulfilled and I love the people I work with. And what I do and delivering a baby never gets old. It's just the best. But also, this part is exhausting and it brings a level of fatigue when already obstetrics is already very emotionally charged. The highs are high and the lows are low. So I wanted to share a few quotes with you to show you the kinds of impacts that this is having on OBGYN's health and well-being. Okay, I just showed that one. I tend to be an optimistic person, but I feel like that's changed. I almost have to compartmentalize my job from the rest of myself so that I don't allow my frustrations to bleed into other aspects of my life. Physically, it's taken a toll just knowing you're not taking the best care of yourself. And mentally too, I feel. There's kind of a constant unease, a feeling of being just uneasy. And I wanted to note that this kind of almost hypervigilance that this participant is referencing is a risk factor for longer-term physical and mental health problems. More of the conversations my partner and I have are, what is the point where we leave? I think that's the conversation I think a lot of OBs are starting to have, is where's the point where you say, you know what, it's not worth it to live here anymore. We both grew up here. We've been here forever. I've never had a point where I've thought that I would leave. And now it's going forward. I think that's a much more feasible idea. It's just not worth it anymore. So speaking about this idea of leaving, I think it's important to note that the decision to leave one's job has to be situated within a broader cultural and political landscape that includes the politicization of medicine and mounting safety concerns, considering rising rates of gun violence. So we really saw that with Dr. Robach's case, in which a shooting in a medical clinic had first prompted her to consider leaving her state. And then Dobbs kind of ended up just sealing the deal for her. 6 participants in our study had moved their practices to states with stronger abortion protections. Of course, we maybe can't make too much of this due to the potential for sampling bias, but I do think that it is an interesting finding. Most others had thought about leaving. 29 out of 48 had entertained the idea of leaving, but most of them were not able to act on this idea because of their family commitments to staying in their state. We often heard this narrative of, you know, I grew up in this state, I moved away for training, but I came back because I really care about the people of this state, and I wanted to kind of invest in the health and well-being of the people in this state. Many also felt galvanized to stay and advocate for their patients in both clinical and political arenas. So I'm going to share another case with you. Dr. Singh, a pseudonym, is a maternal fetal medicine physician who left his job and his state because of a split amongst his colleagues regarding how to handle certain kinds of cases. Prior to Dobbs, his division had all been pretty well ideologically aligned. So it wasn't that his colleagues were necessarily anti-abortion, they simply just did not want to risk felony charges. Things came to head over a preterm periviable rupture of membranes case involving a non-English speaking patient who had been bleeding for several weeks. Dr. Singh told the patient through a translator that he thought they should terminate because this had been going on for several weeks. However, his partner, who came in the next day, disagreed. Anesthesiology also refused to back him up, though the nurses were supportive. It was at this point that Dr. Singh decided to leave. He could not continue to work in a climate in which he couldn't trust the person picking up the baton after him, he explained. Dr. Singh had significant anxiety resulting from this case. He felt angry, embarrassed, and ashamed that his colleagues had let him down. He said he handled it the way that all doctors handle things, just by sticking it out. He had since moved to a blue state that had a good professional opportunity for his spouse, who was also a doctor. But I don't want to suggest that leaving was kind of necessarily a happy solution, because leaving also had personal and professional consequences for those physicians that did decide to leave. One described feeling sad in the aftermath about leaving her patients and how difficult it was to start over after having been in her state for so long. She said, I feel sad about leaving the state, about moving away. I miss my patients. I really liked my patients. I really liked my work colleagues as people. We had been there for a number of years. I miss the social support that we had built up there. And I feel bad because I know that me leaving this state takes a person who has these skills out of the state where there's already such a need. And I'm in a place where there's a lot more people. And this physician also talked about dealing with her own health challenges since her move. And she attributed this to the profound stress that she had endured throughout this process. On the other hand, several participants described really wanting to stay and fight for their patients, and felt that it was important to stay precisely because so many people were leaving. So this physician said, I've thought so many times about leaving, but I'm only one of 3 people really in this state who can take care of a patient who is possibly dying from their pregnancy. And that makes me want to stay. Those who remained in their positions described shouldering an increased burden of clinical care and declining morale as colleagues moved away. Several mentioned challenges of filling vacant OBGYN positions in abortion-restrictive states. So this following passage is from a department chair who told us, I've not been successful at hiring another faculty member. I have interviewed residents this past December. I did a dozen interviews that day, and they all brought up the post-obs reality. A couple of them mentioned specifically that this was the only institution in a restrictive state that they're interviewing at for residency because they know that our residents are getting trained in a neighboring state. So this is an institution that borders a non-restrictive state where they were sending residents across state lines for training. So being a leader has been really hard because I can't even recruit additional people. And while it's true that the actions of the medical school and the hospital have made it easy to point to the fact that we are still here, surviving is the new winning. We're still, I guess, winning. It's not easy. So I think these findings demonstrate the need for healthcare organizations to invest in efforts to support, attract, and retain OBGYNs in restrictive states. We found that some institutions harmed OBGYNs through conservative interpretations of state laws and prioritized institutional protection over physicians' ethical obligations to patients. And this is really something that we're hoping to move into in the next phase of this work is to help develop recommendations for how institutions can support OBGYNs in dealing with these restrictive policy environments. And then zooming out to consider both of the projects that I've presented today in tandem, these findings support a multi-level strategy that acknowledges internal organizational and external factors as shaping clinician burnout and work-related well-being, in addition to individual factors. And I think that focusing on interventions at multiple levels would be more effective at promoting physician well-being than focusing only on individual physician behaviors. These are my acknowledgements, and I think we now have plenty of time for questions and discussion.